Dr. Prabhakar Singh, my co-moderator. He is practicing as a cornea faculty in AIMS Patna, and he will take us through managing how to deal with intrastromal and intracameral injections, and basically how to deal with these formulations.
Good morning once again. So the title here is Intrastromal and Intracameral Antimicrobial Injections. When, why, when, and how. So when I say intrastromal and intracameral antimicrobial agent, I would largely imply antifungals, and I have no financial interest to disclose. To label a keratitis as a case of fungal keratitis, we have to have either a smear positive or it has to be culture positive. And following are the drugs in the armamentarium of the cornea specialist. These are the topical medications that we use, and these medications work quite well. However, at times these medications do not work and our ulcer tend to worsen either because of there is deeper stromal involvement, there is associated severe anterior chamber reaction, or the drug is not reaching the intended site. So what has to be done then? So this is the time when you have to devise a targeted delivery system, either in the form of intracameral injection or intrastromal injection. Why? Because this gives you an advantage of giving, the drug reaches to the intended site and gives the maximum bioavailability. However, there is potential risk of spread of infection to the deeper tissues, and there's also a risk of seeding of the end report. There are various studies in the literature which suggest that these intrastromal injections of antifungal agents are quite safe and effective, especially in cases of recalcitrant fungal keratitis. So with this, I would like to take you through the preparation of various drugs that are being used as intrastromal or intracameral injections. So let's first start with Variconazole. So while preparing a Variconazole eye drop, the 50 microgram intracameral or intrastromal dose, you can prepare it either from the Variconazole eye drop that is available as 1% drop by Orolam, or you can just take the Variconazole injection 200 milligram vial. Let's first talk about the one that we prepare from the vial. So it comes in a form in a strength of 200 milligram. What you have to do is you just have to do double dilution. First, add 19 ml of ringer lactate solution to it. The resultant solution, take 1 ml of that and again dilute it with 20 ml of ringer lactate solution. Now the solution that you will be having will have a concentration of 50 microgram per 0.1 ml. Say if you have access to the eye drop, the Variconazole eye drop, 1%, then again you just take 1 ml of that solution and add 20 ml of ringer lactate solution, and the resulting solution will have a concentration of 50 microgram per 0.1 ml. When it comes to preparation of amphotericin B, it comes in a vial of 50 milligram. Just take a 50 milligram vial, add 10 ml of 5% dextrose to it, and the resultant solution, take 0.1 ml of it and again add 9.9 ml of 5% dextrose, and the solution is ready with a concentration of 5 microgram per 0.1 ml. There are various preparations now available for netamycin also in the form of netasol, though I have a limited experience, so I have not talked much about it. Now, once we have discussed the preparation of the drugs, let's talk about as to when do we need to go for intracameral injection and when we want to give intrastromal injection. I would like to take you through a small case. This is a case wherein, you can see that there is a large central corneal scar and there is superior patch of endothelial exudate. And there is anterior chamber reaction in the form of a hypopion, and there are superficial and deep vessels also. So considering the fact that the epithelium is intact, the efficacy of topical medications, the topical medications won't be able to reach the anterior chamber, but the infection is largely in the anterior chamber. So what has to be done? Here we made a diagnosis after doing an endoscraping, and the endoscrapings were subjected to microbiological evaluation, which revealed fungal filaments. And this is when we planned for giving intrastromal antifungal agents. And this is the outcome after 3 doses of antifungal agents that we had given intracamerally. Now coming to the second scenario, here you can see 2 clinical pictures. In both the pictures, you can see that there are large corneal infiltrate. In the first picture, you can see that the one on the this side, on the left side, you can see that the corneal infiltrate is pretty large, and it's of variable depth involving from superficial to deep, and you can see a thin sliver of clear cornea all around. And specifically, it is threatening the inferior and the temporal limbus. Now, what is to be done here? As the infiltrate is threatening the limbus and is very close to the limbus, if it involves the limbus, the outcome is definitely going to be downhill. So what we can do, and again, there is a paucity of corneal tissues. Ideal would be to go ahead and do a therapeutic penetrating keratoplasty for such patients with a clear margin. But considering the fact that there is a paucity of corneal tissues and also there are not enough transplant centers, we can do our bit and give intrastromal injections. So this is a kind of desperate measure to prevent going it downhill or prevent to compromise the outcome, not to compromise the outcome. This is what we can do from our side. So this was a desperate measure here. Now coming to the clinical scenario, which is on the right side, again you can see that there is a large corneal infiltrate. There are multiple satellite lesions which are reaching the limbus, and you can see this superior part, which is the deep stromal involvement. These infiltrates had progressed in just a matter of 2 days and are threatening the superior limbus. Now here you have to make a timely decision. You have to select your case very carefully and make a timely decision before these infiltrates reach superiorly. Considering such a fast involvement, it's better to go ahead and do intrastromal injections here. So once we have talked about the preparation, we have talked about when to give intrastromal, where to give intracameral. Let's talk about as to how to go about it. So there is a study which talks about as to how to give intrastromal injections. In their study, they had shown that we can divide the cornea into 3 different zones, the outermost zone being zone 1, and the innermost being zone 3, and the intermediate zone as zone 2. So they said that you just have to enter the zone 3, traverse entirely the zone 1, and then enter zone 2, and this is where you have to inject your medication. And there is absolute no to the entry of needle to the zone 1. So here is a short video that I would like to show you as to how to give intrastromal Variconazole. Always remember that you have to be little away from the infiltrate and start from the clear cornea and try to inject. So here you will be seeing that initially there is some sort of air injection which was there in the needle, and subsequently you can see a zone of hydration which ensures that the drug has been penetrated intracorneally. Always remember while giving the injection, the bevel should be up, and until and unless the entire bevel is intracorneal, don't inject. You also have to remember that the level at which you have to inject is the mid-stromal level. And whenever you want to come out, it's always better to take your plunger little out and then come out. This will prevent backflow of the drug. The infiltrate has to be barraged all around, and always take utmost care that you don't perforate the cornea or keep away from the thinned out cornea or thinned out area. And the endpoint is always where your barrage is complete. So with this, I would like to take you to the take-home message that intrastromal and intracameral injection is quite safe and effective, provided you have made an appropriate case selection and you have done it at an appropriate time. Thank you so much.
Thank you, Dr.